Um, we didn't talk a whole lot about antidepressants this semester. And a lot of your patients are going to be on antidepressants. As y'all know, depression often goes hand in hand with chronic illness, goes hand in hand with pain. So often it can go either way. One can lead to the other. You know, when you're hurting all the time and you're in bed all the time, that could lead to depression. And then vice versa, if you're depressed, then it leads to your body just feeling yuck, you know, and leads to physical ailments as well. So the biggest thing, so right now we're like Speedy Gonzalez going through, because these are the all the stuff that I'm about to talk about is the stuff that y'all are doing your projects on. So we're gonna watch those on the second. But there's stuff that I still feel like I need to point out to you guys, okay? So before we talk about antidepressants, let's talk about stimulants. That's in chapter 18. All right, so stimulants. We are all probably have had some stimulants this morning. Caffeine is a stimulant. And other stimulants include medications that treat ADD, ADHD. Sometimes whenever when our surgery and they have drug-induced respiratory depression, we give a stimulant to wake them up. We give them for people with narcolepsy and people with sleep apnea who can't stay up during the day. And then we also give stimulants for obesity. So if you think about a stimulant, we know it's going to speed you up, right? It's going to think about what coffee does to you. It increases your heart rate, it keeps you awake, it speeds you up. So that's what stimulants do. But in a child or an adult with ADHD, they kind of have that opposite effect. Does that make sense? They kind of, if you need, so like people who don't need Adderall are going to, like people who take it like for study purposes or whatever, it's gonna like make them hyper concentrated and it's gonna like speed them up and all of this stuff where they don't sleep. People who need Adderall, it kind of binds to those receptors like we talked about, and they're not as stimulated. They're focused, but they're not hyper stimulated. Does that make sense? Kind of, sort of. But those are the uses. Stimulants can be classified as amphetamines, and the amphetamines begin with methyl or they end with phetamine. Those are your things like Adderall, Concerta, those type drugs, okay? So adverse reactions would include excessive CNS stimulation, headache, dizziness, apprehension, disorientation, hyperactivity, and elevated heart rate. If any of you guys have ever taken diet pills are often, they're stimulants and they're often in the same drug class. And they usually make you feel like that. They give you a headache, they make you a little bit nervous, they make you a little bit, a little bit hyper, make your heart beat kind of fast. All those are side effects of stimulants. Stimulants, when used long term, can cause addiction and abuse. So that's something you need to be aware of. And then as far as your nursing assessment, some of these, the stimulants that are prescribed to children can stunt their growth and it can cause decreased appetite. So in children, we really need to monitor their weight. And then based upon our assessment, depending on what we're giving the stimulant for, that is what we are going to monitor. So if we're giving it for weight loss, if we're giving a prescribed stimulant for weight loss, what are our assessments that we need to pay close attention to?
Wouldn't weight be?
Yeah, how much our patient weighs and their eating habits, essentially. And it's going to be the same thing regardless of what you're giving them to. So if we're giving it for narcolepsy, what are we monitoring?
Sleep patterns.
Yeah, their sleep patterns. How many times a day are they falling asleep versus when they were on the medication, when they weren't. Because anorexiants are stimulants, we usually don't combine them with coffee, tea, all of those things, because remember we talk about those additive effects. We don't want to give one thing that stimulates plus another thing that stimulates, or we're like, our patients are spazzy McGee, right? Do y'all feel okay about that? I mean, there's not a whole lot to say about it. Um, we do not give these medications to patients who have underlying cardiac conditions, because just think of them, for just lack of a better term, think of them as speed. They're going to speed everything up, okay? We've talked about our CNS depressants. So these are our stimulants. They are going to stimulate our central nervous system, which could in turn stimulate increasing our heart rate and everything. So we're not going to give them to patients who already have underlying conditions. Any questions at all?
For children, you said it stunts their growth, and what about their appetite?
It suppresses their appetite, and it can stunt their growth. So that's a big thing when not students, when children are prescribed ADHD medications. They have to get continuous monitoring of their height and weight. Sometimes they have to take a drug holiday, or sometimes they have to be changed their medications. If that growth, they're tracking on a growth chart. If it is stunted too much, then, very often they'll have to change medications. And about it that sometimes these stimulants are given for weight loss. That kind of makes sense, right? Like, the weight loss, like, the Aspen Clinic, Professional Weight Loss, all those clinics, they prescribe stimulants. So those are just your high points on teaching there. All right. Chapter 19. And I think some of y'all have picked some of these medications. So again, this isn't the only exposure you'll get. But just in case we don't go over it, I'm afraid to just not touch on it at all, So chapter 19, we talk about cholinesterase inhibitors. So we know that choline is a neurotransmitter, right? Do we know that? Maybe sort of kind of heard of it before. Acetylcholine is a neurotransmitter that is used in our brain. And whenever people have Alzheimer's disease or dementia, they often have their acetylcholine levels that acetylcholine is not acting in which it should, right? So, so those impulses aren't being transmitted the way they should. Point A is not sending the signal to point B to tell the patient to speak or to eat or to walk or whatever. And so that's why you see these patients deteriorate. That's why you see confusion in these patients. So cholinesterase inhibitors are used to treat dementia associated with Alzheimer's disease. And the biggest thing that you need to teach with these medications is that there is not a cure for dementia. There's not a cure for Alzheimer's. The goal is to slow progression. Examples of these medications are Namenda, Aricept, and Exelon. Exelon, I don't know if y'all have heard of these medications or seen these medications. My mom was put on, I think I told y'all that she had metastatic brain cancer, or she had breast cancer, but it went to her brain. And when they knew that she had brain mets, they put her on Namenda. She didn't have any forgetfulness yet, but they knew that those transmitters would be affected, by the tumors in her brain. So they wanted to slow that progression. So that's one of those, that's one that's used to slow progression. When patients are first diagnosed with Alzheimer's, they're often put on Aricept, or they start having that forgetfulness early on, and they're pinpointing it, and they're pointing, all signs are pointing towards dementia. They put them on these meds. And then Exelon comes in a patch that is placed on the patient. So if we're placing this patch on a patient that has Alzheimer's disease, we usually want to place it on either on their back or their upper arm, somewhere where it's not visible to them, where they're not going to pick at it and take it off, okay? Because they might forget what it is. And with these medications, almost always, if you can think about why we're given the medication, you could think about what we're monitoring. So we're given these for Alzheimer's disease. So what do we need to assess? In our patients with Alzheimer's and dementia, what do we need to assess?
Safety?
Say again, I'm sorry.
You're gonna cut cat off.
I didn't hear you, Kelsey. Or whoever's talking, I can't hear y'all, I'm sorry.
Your cognitive ability.
Yes, their cognitive ability. Yes, we need to know where they are. We need to know where they are before drug therapy. We need to know their functional ability too. Are they able to remember how to put on their socks, a week ago and now they can't? Or, they were able to remember how to put on their socks and 6 months later they can still remember how to put on their socks and there hasn't been any decline. That's how we're going to measure the effectiveness of these drugs. And we're going to educate our family members regarding keeping them safe. All right, that's it. Y'all feel good about that? Okay. Anti-anxiety medications. Anti-anxiety meds we've talked about briefly, right? When we talked about when we talked about surgery and when we talked about, what other chapter was it in? Something else. We talked about it in a surgery chapter and one other chapter, but I can't remember. Oh, when we talked about seizures. Oftentimes, anti-anxiety medications are given for seizures. So anti-anxiety meds can be given, they can be benzos, which are benzodiazepines, or they can be non-benzos. So benzos have a chance for physical dependence and psychological addiction. These are lorazepam, temazepam, Valium, all of those medications, your LAMs and your PAMs. Remember I told y'all about your OLOLs you needed to remember forever? You need to remember forever that benzos end in LAM and PAM. Things that you must know about benzos. They're used for a lot of things. They're used for anxiety. They are used for pre-anesthetic sedatives. Remember I told y'all we give Versed before surgery. Versed is a benzo. Muscle relaxants, we give Ativan for seizures. That is a anti-anxiety benzo. We give them for seizures. We give them for alcohol withdrawal. So they can be used for a number of things. And a generic name, like I said, ends in LAM and PAM. Non-benzos have a lesser chance of addiction, but they are also useful anti-anxiety drugs, okay? And I have examples on the next page. So both of these medications, now just because we say this, know that it's not always, both of these medications are meant to be used on a short-term basis, okay? Does that mean that people don't take anxiety medications for their entire lives? Some people do. It's a risk-benefit thing, but ideally they're only to be used on a short-term basis. Benzo withdrawal symptoms may occur with as few as 4 to 6 weeks of therapy. So if your patient is on benzos, they're not going to have withdrawals if they just take it before surgery, right, to help them go to sleep. They're not going to have any kind of withdrawal. But if someone has a spouse that dies and they just really are not doing very well getting through it, and their doctor puts them on Xanax, which is alprazolam, their doctor puts them on Xanax and they take it for 6 weeks, they cannot abruptly stop their Xanax after 6 weeks. They have to be tapered off. If they abruptly stop, then they are going to have benzo withdrawals, which is going to be an increase in anxiety, concentration difficulty, tremors, and sensory disturbances. So they're going to be like hyped up, super duper duper anxious, okay, when they come off of these drugs if they're not tapered off. That's very, very important. Now, if they're used for short periods, a week and a half, 2 weeks max, tolerance, withdrawal, and dependence do not usually develop, okay? So we're talking greater than 2 weeks, especially after 6 weeks, okay? Now, benzo withdrawals also don't really take place if the medications are not, if you're taking, okay, like my little mama, her doctor gives her Xanax as needed, right? But she only takes it like, she takes like a half of a half every probably 3 months. Is she going to have withdrawal symptoms? No, because those are isolated events. She's taken them when her husband has surgery or, something like that, when a big event in her life takes place. Those people are not going to have withdrawal symptoms. The biggest non-benzo examples are hydroxyzine and buspirone. Hydroxyzine is one of those drugs that's used for, a number of things. It's used for anxiety. It's used for itching. It's used for, there's something else that it's used for that I can't think of. Oh, pre-sedation in children. Like whenever kids go to like the dentist and they're getting some light sedation, they'll usually give them Vistaril by mouth, okay? So that's an important drug to remember. Questions about benzos, non-benzos? What do benzos end in? Good. All right, so the biggest thing is with this education regarding safety, which we know already. They need to take their medications as directed. They don't need to take them, so-and-so's anti-anxiety medications down the street because they're anxious and they gave them a Xanax. Not acceptable. They don't need to drive. They don't need to drink alcohol. They don't need to discontinue the drugs abruptly. And they need to be really careful with medications that might it's kind of one of those drugs that we need to know everything that they're taking, because over-the-counter medications could potentiate the effects of these medications. So just making sure that their dentists are aware, their physicians are aware, that everybody knows when they're prescribed these drugs, so that we can make sure there's no drug-drug interactions. All right. Sedatives and hypnotics. I know some of y'all picked this drug class, right? For your, I don't remember who it was. You did, Kelsey. So sedatives and hypnotics, we are going to be giving more so than, okay, so there's sedation. Well, let me not say sedation. There's anti-anxiety medications, which are meant to relax. Sedatives and hypnotics are even deeper than that. They're made to put you straight to sleep, okay? Like, they're made to, like, put you into a deep sleep. So they're used more as sleeping pills rather than just to decrease anxiety. Does that make sense? So these are your things like Ambien, and Lunesta. I've got some examples over here. Nope, I don't have any examples. Were they on here? Nope, I didn't put them on here. But these are things like Ambien, Lunesta, your sleeping pills. And then remember I told you we don't use barbiturates much anymore because they're pretty dangerous. Barbiturates are used for conscious sedation. And they're going to be used for before procedures. So the biggest thing we're doing with these are safety. We're not combining them with alcohol. And if your patient is taking sleeping pills, very often they induce forgetfulness. I always tell a story. A girl I used to work with kept having these random packages show up at her door. And she's like, what is all this crap? I didn't order this. And her mom was living with her. Her mom was on Ambien, and her mom was getting up in the middle of the night ordering stuff from the home shopping network and had absolutely no recollection that it was taking place. So it was like crazy stuff that kept getting delivered. And my friend was like, "What is all this stuff?" And her husband was like, I'm not ordering it. And everybody denied ordering it. And anyway, come to find out, Mama was high on Ambien ordering everything on the home shopping network. So, for that reason, we don't leave sedatives and hypnotics near the client's bedside because often they don't remember taking them. So, they need to take them and then put them away. Um, doors need to be locked, like making sure that when they take these drugs, they have a good solid 8 hours to sleep. We're not taking Ambien at like 4 in the morning, because you're still going to have it in your system by noon the next day. So those are the biggest thing, assessing level of consciousness and safety. And again, alcohol doesn't really combine with any of these things well. Questions? I'm going to start blaming it on Ambien when I accidentally order too much stuff from Amazon. That's what I'm going to do.
Question, but it's more random. For the project, like, can I use the trade name instead of the really hard to say generic name?
You can, but you need to include the generic name as well. So when
Okay.
you're talking about the drug, you don't have to fumble through the generic name, but it does need to be included somewhere on your project so that we can associate the two together.
Okay.
Most of the time on NCLEX and my exams, you'll have both names, to go by. So that's fine.
Okay.
And then, so y'all feeling okay so far? Am I overwhelming y'all with lots of information? I tried to condense it as much as I possibly could. And again, we're going to go over this on Monday when we watch our projects. And excuse me, because I have to blow my nose. I'm sorry. Let me mute it so you don't hear it. It's disgusting. Sorry. All right. Okay, antidepressants. All right, so we're moving along, hardcore along, okay? We are on chapter, I think we're on chapter 22. All right, so antidepressants, y'all talked about them briefly in Miss Adams' class, right? Y'all talked about just the classes and what they're used for. The high points with antidepressants, you must know the symptoms of depression. You must know, um, you know, that when people suddenly begin staying in bed all day and that's not their norm, when they stop eating or they're eating excessively or they're crying, excessively, or they're completely not themselves. They're in shutdown mode and they don't care about anything or anybody, or they're just it's usually a big change from their baseline. Those are things that you need to take in, and those are assessment findings. You know what I'm saying? People might not always say, I am depressed, but they might say, oh, I just don't really feel like eating anymore, and I don't see the point, and, I can't think of any other examples, but just because they don't have to say, I am depressed for you to recognize those signs and symptoms of depression, okay? And that could be found on page 235. Restlessness, irritability. It's not just those typical like sadness. Sometimes it's fatigue and restlessness, and usually a combination of all of those things is you should take note of that, okay? And take note of what's going on in their lives. You can have temporary episodes of depression related to life events that are taking place, or you can have chronic depression, with, specific chemical imbalances in the brain. Um, so all of that. So treatment is going to depend on, you're not going to decide the treatment naturally, the physician is, but it's going to be dependent upon how often their depressive episodes are. do they have an underlying disorder like obsessive compulsive disorder, bipolar? Is it related to chronic neuropathic pain? Do they have bulimia? Is it just related to their cycle? Do they have premenstrual symptoms that are off the charts that are causing problems in their relationships? Like to the extent of it's interfering with their lives and it destroys their relationships for 2 weeks and then they're back to normal, so to speak. So these are all the things that your physicians are going to take into account. And those are going to be the things that you're assessing, in regards to, are these medications effective? So the first class are your tricyclic antidepressants. Adverse effects apparently are dry mouth instead of dry mouth. So I'll fix that later. Dry mouth, constipation, and sedation. Okay, they're gonna make your patients kind of tired, and some of those aren't like big deal side effects, but they're annoying, especially when you're already depressed and your mouth is just like sticking together, and you're like, those things get frustrating. So instructing them to suck on hard candy, take frequent sips of water, anything that they can do to lessen those annoying side effects is helpful for your patients. Tricyclic antidepressants end in triptyline. And then some outliers are doxepin. And there's some others that end in Pramine, Pramine. We do not give tricyclics with MAOIs, and we don't give them to people with glaucoma, and we don't give them to people with pre-existing cardiac conditions. All right, MAOIs. I want y'all to look on page 239. I know y'all have heard me say this drug class a million times. We know that it has many, many drug-drug interactions, right? They don't go with tricyclics. They don't go with decongestants. But one of the biggest things that they do not go with is the product tyramine, foods with tyramine in them, okay? Or tyramine. People say it differently. Examples of foods with tyramine are on page 239. And I don't know, I just kind of made this up. It kind of reminds me of like bar type foods, like aged cheese, beef, fermented meats like pepperoni, but certain kinds of nuts, different little like party type foods have tyramine in them. Caffeinated beverages, chocolate, that chart's on page 239. So that's a very big teaching point for your patients with MAOI who are taking MAOIs. It can cause a hypertensive crisis that could potentially be life-threatening. So MAOIs usually are not the first-line treatment for depression because of this. And again, it's a risk-benefit thing. So if we're fixing to talk about first-line treatment are your SSRIs, which we have not talked about yet. They are right there. SSRIs are usually first-line treatment, and then you kind of go from there based upon, again, the underlying cause of the depression and the effectiveness of the medications. So MAOIs, these are your three right here, Nardil, Parnate, and Marplan. Those are the brand names of your most common MAOIs. Excuse me. All right, we're going to skip lithium. It's kind of out of order. SSRIs are your most commonly prescribed medications for depression. They're used for PTSD. They're used for anxiety on a lesser level. So if you have social anxiety, social phobias, anxiety that is not, we want to try SSRIs before we try benzos, right? So those are the things, like this will usually be the medications that people are put on as like first line treatment for a plethora of things. So again, it's the same kind of things: depressive episodes, bulimia, panic disorder, premenstrual disorders, PTSD, anxiety, Raynaud's, which is the discoloration of your fingers. It's a little, y'all learn about that in Miss Adams' class. Sometimes people are put on these for migraines, diabetic neuropathy, and hot flashes. Of all your drug classes, these will be the most commonly prescribed. And if you don't remember anything, I mean, I want you to remember all of them, but you're going to see, I think I told y'all this before too, in your society, you're going to see a whole lot of people who take antidepressants. A, the state of our world. B, the fast pace of our world, people just feeling like they can't keep up. Self-medication. And chronic illnesses. So you're going to see sick people, and oftentimes sickness and depression go hand in hand. So you are going to see these drugs a lot, and they probably already look familiar to you guys. Most of y'all have probably already heard of Zoloft and Prozac. Paxil, you're probably already seeing a lot of your patients on these medications. Effexor, Cymbalta, one that I did not include, but it's not an SSRI. You're going to have a lot of patients on Wellbutrin, bupropion. It's a non-specific antidepressant. So the biggest thing, all antidepressants have the risk of increasing suicidal ideation. And the reason for that, or what they feel is the reason for that, a lot of times people are already depressed and they already have suicidal thoughts, but they don't have the energy, they can't get themselves together enough to carry out a plan. And sometimes when they are placed on antidepressants, gives them they're almost like they're feeling good enough to kill themselves. I don't know if that makes sense. But they kind of get this like, okay, well, let me just follow on through. So a lot of people are fearful of antidepressants for that reason. And that is a very important teaching point. We need to ask them about their suicidal intent. Those are always going to be uncomfortable questions to ask your patients. Do you have thoughts of harming yourself? Do you have thoughts of harming others? But you have to ask them in a straightforward way, because people are going to tiptoe around them if they can, because just like they're uncomfortable to ask, they're uncomfortable to answer. So you really just want to make sure that you're assessing suicidal ideation for patients who are on antidepressants or being placed on antidepressants. And then their mental status, their subjective feelings, when they say things like, I don't want to live anymore, delving a little deeper into those, or I've had to tell many patients, like, when you say things like that, it concerns me. Are you just saying that like to say it because it's a figure of speech? Or are you saying it because you really don't want to live anymore? Like sometimes you need to, patients will sometimes say like, oh God, I'd rather die than be in the hospital. Would you really rather die than be in the hospital? Assessing the difference between, figures of speech and people who actually have suicidal ideations. You'll have to kind of address that. And any changes in their norm, slowness to answer questions, monotone speech patterns, wanting to be alone more, all of those things should kind of throw up red flags for you to monitor. And to let your patients' families know, to let us know should you experience or see any of these things. Questions? Okay. Excuse me. Okay, sorry, I already did that. Antipsychotics are different. I don't want y'all to group antidepressants and antipsychotics in the same, they're two different drug classes. Antipsychotics are used for episodes of psychosis. which is not just depression. They're used for things like people who have paranoia, or they, have schizophrenia, or they have they're very agitated, like very, very agitated, or they um, are super duper confused, like they have dementia, but they're like, you know, they think that they're in like combat fights in the house, things that are not reality are going on in their life, more so than just having those imbalances. So actual psychotic symptoms. You can have acute psychosis and you can have chronic psychosis. I say the biggest, one of the things patients with antipsychotics are often, when they get to feeling good, they don't take their medication. So compliance is a really big deal with your patients with schizophrenia, your patients with bipolar disorder. They're often not compliant with medications. And noncompliance, of course, leads to relapse and, bigger issues. Um, General symptoms, um, system reactions with antipsychotics are headaches, dry mouth, photophobia, and photosensitivity. So they can be very sensitive to light. Um, and then intensity. So sometimes when they start these medications, they'll either be incredibly tired and not get out of the bed, or they'll be the other end of the spectrum. They'll be super hyper, and it's difficult to find a happy medium of antipsychotic medications for that reason, because they're very much, they kind of are all over the place with their symptoms. So these medications, um, remember the little guy we watched when we were talking about tardive dyskinesia? Okay. This antipsychotics, not antidepressants, but antipsychotics can cause tardive dyskinesia. So that's something that we need to look for on patients with patients taking these medications, those extrapyramidal side effects. Um, Akinesia and dystonia, those are, things associated with those extrapyramidal side effects. And they usually diminish with the reduction of dosage. So that's one of those things, again, you have to, if you remember that guy saying in the video, I can't remember his name, but, it was the best he had felt in years. So he didn't really care about the side effects. Then later he did. So it's just finding, a happy medium with the treatment versus the adverse effects of these meds. We need to assess their mental status. We need to record the presence of hallucinations and delusions. We need to obtain complete mental health, social, and medical history. And then something we haven't talked about, we need to document our psych patients, the ones both on antidepressants and antipsychotics. We need to note how they look, not in a judgmental way, but if they're very put together one week and the next week they're completely disheveled and they haven't taken a bath, those are things to note. Those are changes in their behavioral patterns. So that those are assessment findings that you need to take into account. Excuse me. We need to, if your patient is being very violent, these drugs are often given parenterally. We'll give them a shot if they're extremely violent, because it works quicker. And then your patients, these patients, and sometimes it's not just them being ornery, it is their psychiatric diagnosis that causes them to be paranoid. So obviously, that's why they're taking these medications. So you'll be giving them their medications, and in their brain, it's like, oh, you're giving me this medication to kill me, so they won't take their medication, so they'll put it under their tongue. So making sure that the medications are actually taken, not just trusting them to say, here you go. A lot of your, and I hate to call them psych patients, a lot of your psychiatric patients or your patients with psychiatric disturbances will pocket their medications, in the back of their mouth. They'll hide them under their pillow. I feel like I don't know the right word. I don't want to put them all in a box because each of your psychiatric patients are different. But oftentimes they have sometimes have those manipulative behaviors, but they're often a defense mechanism as related to their diagnosis. Like they're not just manipulative people. They feel like people are out to get them because they have paranoia. So they are protecting themselves by doing those things in a way. But being mindful of that is important as a nurse. You need to, discuss about the sun exposure, discuss about the adverse reactions of these medications and that they do cause dry mouth. Clozapine is only dispensed 1 week at a time. This drug is a typical antipsychotic medication, and there's a special program because it is one of those medications that we have got to monitor for toxicity. And so it's only given a week at a time. You'll never see a month's supply of that given at a time. And I could have sworn that I put these examples. Oh, here they are. So first generation examples are chlorprezine, haloperidol, which is Haldol, and Thorazine. And then second generation examples are here. This is Seroquel. Quetiapine is Seroquel. You'll see that a lot. All right. Questions about antipsychotics or any of the drugs that we discussed? And I skipped the lithium page. We need to talk about lithium. Lithium is the most commonly prescribed drug for bipolar disorder. It is another medication that drug levels must be monitored. It is given in more than a week dosing at a time. But signs and symptoms of toxicity can vary greatly. If you look on page 240, at low levels of toxicity, it can cause diarrhea, vomiting, nausea, drowsiness. Then higher levels would be giddiness, blurred vision, tinnitus, vertigo, increasing confusion. And then greater than 3 milliequivalents per liter may produce complex clinical pictures involving multiple organs and organ systems, seizures, arrhythmias. So if you're extremely toxic with lithium, it could be life-threatening. So those are, again, one of those things that we really need to monitor because oftentimes your patients with bipolar have highs and lows. So sometimes they'll want to take their medication and they're feeling great, and sometimes they're not getting out of the bed for several days and they're not taking their medication. So it's very important that we know that these medications need to be monitored closely. Do you have questions about any of the psychiatric medications or stimulants or anything like that? I think they're pretty interesting drugs. I kind of wish we spent a little bit more time on them, but y'all have mental health too, and you'll be kind of, repeatedly introduced to these drugs throughout your nursing career. So let me end that recording.